You are listening to Medscape's In Discussion series on colorectal cancer, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Benjamin Schlechter. Dr. Schlechter is a senior physician in gastrointestinal oncology at the Dana-Farber Cancer Institute. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Benjamin Schlechter, and welcome to Medscape's In Discussion series on colorectal cancer. Today, we're discussing treatment options for refractory colorectal cancer with Dr. Cathy Eng. Dr. Eng is a professor of medicine, hematology, and oncology at the Vanderbilt Ingram Cancer Center, as well as the co-director of GI oncology and co-leader of the Gastrointestinal Cancer Research Program. She's also a recognized expert in colorectal cancer and a prolific clinical trialist. Thank you for joining us today, and it's great to have such a distinguished guest. Before we start to talk about these treatment options for refractory colorectal cancer, can you first tell us a little bit about your path to becoming a GI oncologist?
I was trained at University of Chicago and was exposed to GI medical oncology at that time. I originally was a head and neck fellow, so wasn't a clear path. And then I went to MD Anderson to look at a job position, and I ended up taking that job position, actually. And in fact, now I became a GI medical oncologist. And so things changed a little bit in my career. It just seemed like a great opportunity. And also, it was at the time when a lot of new drugs were becoming available to patients with colorectal cancer. And it wasn't just 5 of you anymore. And so I just really looked at the landscape and decided that was what I wanted to focus my career on.
That seems to be a theme as we go through these interviews with all these distinguished oncologists, that not a lot of people start their career thinking, I want to be a GI oncologist. But many of us see the light. I had the same path. I thought I was going to be a lymphoma doctor, and now I'm a very happy colorectal oncologist. So it is part of the story, and I think it's also so important that we expose fellows, for example, to these drugs and diseases so they can find the inspiration and really seek to treat them. So moving to the topic today for refractory disease, I think for the purpose of this discussion, we should define refractory colorectal cancer. And for today, let's just call that colorectal cancer patients who have had prior fluoropyrimidine, oxaliplatin, irinotecan, and a monoclonal antibody such as bevacizumab, panitumumab, or cetuximab is appropriate. So beyond targeted therapies for rare things like BRAF and HER2, our options are actually pretty limited, and we are treating patients with trifluridine with tipiracil plus or minus bevacizumab, with regorafenib, and most recently with fruquintinib. So let's first talk about trifluridine with tipiracil. The initial phase 3 data for this came out of the RECOURSE study in the New England Journal of Medicine by Dr. Mayer and colleagues, and this was a very large randomized trial that looked at trifluridine versus placebo in refractory colorectal cancer. There were a number of interesting findings from this. So first of all, it looked at performance status as an endpoint, and I think this is a helpful metric in advanced disease. It also showed that trifluridine with tipiracil delayed progression of worsening of performance status. So patients' performance status was maintained for 1.7 months longer compared to placebo, and that was statistically significant. It's a 7-week benefit, but it still is meaningful in very advanced disease. There was also an improvement in overall survival to 7.1 months from 5.3 months, but the PFS data was really a 2-month benefit versus 1.7 months benefit. So benefit, but limited benefit. So in your experience with trifluridine with tipiracil, how do you use this drug with patients? How do patients respond to this agent?
And I'm presuming you're talking about just single agent use and not combination.
Yeah, let's start with single agent. We can talk about the combos later.
For single agent use, that's obviously a very select setting because we do have data, as you're going to mention later on, in combination with bevacizumab where it appears to be more beneficial. But there are obviously some patients that cannot receive bevacizumab as a result of having fistula formation or maybe some other medical condition that does not make them a good candidate for anti-VEGF therapy. So when I think about utilizing TAS-102, I mean, it does have an advantage, obviously, in the sense that it's an oral agent, and that is quite beneficial in regards to quality of life for patients, so they don't have to keep on traveling back and forth extensively for an IV injection. As you've seen the data, and as many of our listeners may be aware of, there is concerns about myelosuppression. That is one component that really needs to be followed closely for individuals that are placed on this agent. I think it's very important to keep in mind that both of us are in academic medicine, and I would say that most of us probably try to find a clinical trial for our patients when we're thinking about the third line setting and moving forward. But if I don't have a clinical trial available, I do consider oral agents such as this and others that we're going to mention later on kind of like a bridge until a clinical trial is available. And I think overall, excluding the myelosuppression, I would say it's tolerated very well as a single agent. And I think that's meaningful for a patient because once again, we're talking about patients that are surgically unresectable with metastatic disease. And we want to be able to provide them whatever options we have available to us that are tolerated well to with good quality of life to improve their overall survival.
And how do patients do in terms of navigating this drug? It's kind of a funny schedule.
I think that's a great question. And I think that's one thing that we have to be very careful. Patients really need to be educated well. I remember, I think probably one of my very first patients that received this. And even though she met with our PharmD, she was given explicit instructions and somehow misheard us and did not read the information provided to her and took the medications, including on the weekends, that ended up with severe myelosuppression and grade 4 neutropenia. And so she felt horrible, unfortunately. And that's because she didn't follow the schedule, which is days 1 through 5. And then it's basically 2 weeks in a row. The way I like to give it, it's 2 weeks on, 2 weeks off, and for 5 days of each of those 2 weeks. The way I like to give it is Monday through Friday. I think that's the easiest way to remember how to administer it for patients. And that they really need to have a calendar in front of them to ensure that they are taking it appropriately. So that's what I like to do.
Yeah, I always try to get the Monday through Friday dosing as well, but it's hard because I don't see patients on Monday, for example. I've sat down with patients with a calendar as well. I find that useful, and getting pharmacy support is really, really helpful. So that's great insight. Thank you for that.
Thank you.
You mentioned the addition of bevacizumab, and I think that's really important. So let's talk about Sunlight for a second. So Sunlight looked at trifluridine plus or minus bevacizumab. This was also published in the New England Journal this past year by Prager and colleagues. So this was conducted in both Europe and the US and looked at the addition of bevacizumab. And here again, we have a positive trial in refractory colorectal cancer. Obviously, is always encouraging. The overall survival was increased to 10.8 months from 7.5 months, which is a difference. PFS was also increased to 5.6 months from 2.4 months. Honestly, the results of Sunlight look pretty good to me compared to trifluridine alone, but it's still a pretty modest benefit. And there seems to be good evidence that the addition of bevacizumab helps here. So how do you think about these data? Are you using bevacizumab routinely? Is that your go-to in this combination?
Great question once again. So I have to be honest, many of us have been utilizing the combination with bevacizumab since the original phase 2 study was published because it resulted in an approval for NCCN guidelines. And as a result, many of us felt comfortable moving forward in that fashion. As you mentioned before, with just single agent, there was only a difference of 1.7 months. And so, when we saw the phase 2 data, we felt that that was the most promising. And once again, for any patient that's a good candidate as well for bevacizumab, I think many of us had started utilizing it. And that is why, if you look at the Sunlight demographics, you'll see that a smaller component of the patients were from the United States, and most of the patients were overseas for the study. And that was the main purpose of the study.
And are there any findings like anyone who seems to not benefit from this trial, or is this a pretty good combo across all subtypes of colorectal cancer?
I would say overall, once again, you wanted to have a compliant patient with good bone marrow, great blood counts before pursuing this regimen, and they need to be followed closely in regards to their blood counts. But I would say overall, based upon the data that we have currently, there's not any particular patient that should not benefit from it unless, once again, they have significant myelosuppression at baseline or they're not a good candidate for bevacizumab, which we all know there's several contraindications if you've had a recent CVA or MI or other medical problems that may be hampered by utilizing bevacizumab. We don't want to use that combination.
Excellent. Yeah, it is helpful to have a drug for refractory disease that's sort of agnostic to left versus right and agnostic versus RAS, a mutation or wild type, things like that. Although probably by this point, most patients have acquired a resistance mutation.
I do want to mention, though, that trial was specifically for the third line setting relative to other trials that have been conducted.
Yeah, and that's also a very important point. This is a very heavily pretreated population, yet patients really did benefit. And I think, at least in my clinical practice, I do find the agents helpful. And I have a subset of individuals with prolonged disease control. But I would say objective responses, I don't know that I've ever really seen an objective response with trifluridine.
Yeah, I would say not by RECIST criteria by any means in regards to clinical, what we expected from a clinical trial. But yes, I would say that I've had a lot of long-term patients, but not a dramatic reduction in tumor burden.
So the other member of this trifecta of refractory colorectal cancer agents is regorafenib. And this has been a a challenging drug for a long time for those of us who treat these patients because it's a tough drug. So the CORRECT study was published in Lancet in 2013, and Dr. Grothy and colleagues were the authors here. And this looked at full dose regorafenib, 160 milligrams daily, 3 weeks on, 1 week off, and that was versus placebo. There was also the CONCUR study in Asia, published in the Lancet Oncology by Lee and colleagues with very similar findings. What they saw was a pretty minimal increased overall survival of 6.4 months versus 5 months. And the PFS was nearly identical, 1.9 versus 1.7 months. So pretty limited benefit with this agent. And half of patients had some sort of a grade 3 toxicity. So where do you fit full dose regorafenib, 160 milligrams, in your practice, if you fit it at all?
So the only time I utilize full dose regorafenib is when I have to as part of a clinical trial as a standard of care arm. And that's because it's in the FDA insert. If I utilize regorafenib, I never utilize it at the full dose. I always start off at a lower dose. And also, I think you're going to mention the redose trial from my colleague, Dr. Saab. I think we have learned that after the regorafenib was approved, there are associated toxicities that are very difficult for the patient to bear. And we need to start them off at a lower dose in order for them to tolerate the drug well and to have benefit. Because obviously, if they stop the drug prematurely before you even get restaged, it benefits no one. And the patient is not feeling well at all. And so it's a quality of life issue. And so I fully recommend a dose reduction before initiation of any further therapy.
So that was actually one of the interesting findings in the CORRECT study. They did look at quality of life the same way the trifluridine studies did. And actually the quality of life in the treatment and non-treatment arms was about the same. So essentially getting sicker from cancer and getting regorafenib kind of had the same quality of life, which is always a disturbing finding.
Well, if I recall, I think the median lines of prior therapy was very high, 4 or 5 prior lines of therapy, if I'm correct. Because at that time, we just didn't have a lot of treatment options, to be honest. So when the drug was approved, I would have to say that, it provided us another option, right? We're always looking for options for our patients to improve their overall survival. And at that time, it seemed very reasonable. But it was a very heavily pretreated patient population from what I can recall.
Yeah, it was a heavily treated population. It was a tough drug, but I think it was an important innovation. And I think it's gotten a lot of sort of negative press a little bit in the published literature, but at the same time, it's an effective drug. And you referenced the redose study. I think that's actually a really important innovation in this agent. So redose looked at regorafenib 160, the full dose, versus a dose escalation strategy, starting at 80 milligrams a day for a week, and then going week by week to increase up to 160 milligrams as tolerated. And most patients land around 120 milligrams. That was also in Lancet Oncology by Dr. Saab, as you said, published in 2018. And for me, that really improved general access to regorafenib. The other thing that was built into the redose study was prophylactic clobetasol, where patients were randomized to receive clobetasol to their hands and feet versus no clobetasol. So it could be reactive or prophylactic. Unfortunately, that actually didn't show a huge impact, and that was published in the Oncologist in 2021. So overall, you referenced this. So are you using this as an approach for your patients with refractory disease?
Utilizing clobetasol?
No, utilizing regorafenib redose and clobetasol.
Yes. So definitely, whenever I consider regorafenib, I do consider the reduced dose as suggested by redose. I think it's very, very reasonable to consider that for patients, and then you feel more comfortable moving forward. If I do utilize regorafenib, I have not historically, though, been utilizing clobetasol as prophylaxis. I have utilized it in some select settings, but not from the get-go, to be honest. I think with the dose reduction, the starting dose being reduced, I think that it really decreases our risk of hand-foot skin reaction, and we don't have as much of an issue with having to use clobetasol. That's why I've not utilized it for prophylaxis.
Yeah, I don't use it either. The other interesting finding about the redose study was there was a trend towards improved survival, not statistically significant, but I think that's meaningful. But also patients received more cycles of therapy because of redose. So how do you see that information?
Yeah, once again, I think it's a really important study in the sense that even though it was not a big phase 3 study by any means, it was informative. And it really changed practice patterns. And I think it's a practical application from literature, which we don't see necessarily a lot, where they tried to revise the dose. I mean, look at capecitabine, which many of us have been giving for years. None of us use full dose. And so I think it was a very important paper to really educate practitioners on how to treat patients appropriately without harming them. So I'm fully supportive of that approach.
Yeah, it's a great point also about capecitabine. I could probably do a whole podcast on capecitabine. It is, I have a love-hate relationship with capecitabine as a GI oncologist for so many reasons.
I think that's another topic.
Yeah, it really is. I mean, capecitabine really, it's an interesting drug. It was a great attempt at a logical design for a fluoropyrimidine, and I wish it were as good as it should have been.
I mean, I think we have to remember when it was approved, right? It was really when there were no option.
Yeah. And we live in an era where we have good enough science that we can design better fluoropyrimidines, and there are some companies out there that are working on that. And I hope that we have a chance to talk about the new 5FU someday, because if we could improve 5FU, that would be great for so many patients.
I agree.
All right, so now let's talk about fruquintinib. This is a really interesting drug. Like regorafenib, it's a multifunctional VEGF TKI. Like regorafenib, it's a 3-week on, 1-week off dosing, so it's reasonably simple and straightforward for patients to do. So we had the recently published FRESCO trial in The Lancet, led by Dasari and colleagues, and this showed an increase in overall survival to 7.4 months from 4.8 months, with a PFS increase to 3.7 months from 1.8 months. So it's hard to make comparisons between trials, and frankly, we probably shouldn't, but of course we always do. But this seemed better than regorafenib, and yet when I look at the data, I do see a lot of adverse events. 60% of patients had some sort of grade 3 adverse event, most commonly hypertension, but also hand-foot syndrome and asthenias. So now that we have fruquintinib here, do you use this drug? How do you use it? How do you think of it in the context of regorafenib and trifluridine? Where does this one fit?
Yeah, great question. So just friendly reminder, it's FRESCO-2, because FRESCO is a separate study that was conducted in China, which was specifically for the third-line setting. And that's why there's the FDA approval for third-line plus, because it was a summary of the 2 trials. Also, just for another clarification, it is a very selective TKI for VEGF receptors 1, 2, and 3, and not any other targets. So it's a little bit different. The regorafenib, how do I utilize it? I utilize it in the refractory setting. Because it has a third-line indication, I have also utilized it in certain patients that are not good candidates for TAS 102 in full disclosure. And it's not just because I'm the senior PI doesn't make me partial to this. I always look at all these drugs as various options for patients when we need to provide them options to improve their overall survival. Overall, I found it to be tolerated very well. And in full disclosure, obviously, I've had clinical trials that have involved this agent, and that's why I've enrolled and had a lot of experience with this agent. I believe it's tolerated very well. Of course, hypertension is an issue for this class of drugs. It's a class effect. But you and I both know hypertension can easily be treated if the patient is compliant with taking their medications as directed. I think it's just another great option. And now we have 3 oral agents that are available to patients in the refractory setting. As I mentioned earlier, for a patient that has underlying myelosuppression, this is my go-to. This actually has happened to me recently where a patient had a very low platelet count that did not allow him to participate in a clinical trial, and there was no other etiology, and I did not want to risk that with TAS 102, and so he was on fruquintinib. And it's a single agent, and that is advantageous as well for patients that don't want to go in for the IV bevacizumab.
And so how do you sequence out your refractory patients in standard of care, obviously outside of a clinical trial? Because not all patients have access to a clinical trial. Not all patients want a clinical trial. We often don't have clinical trials to offer in refractory colorectal cancer. So you're facing a patient who's had 5FU, oxaliplatin, irinotecan, monoclonal antibodies. What's first, second, and third? What sort of informs your decision-making here?
Yeah, once again, it is a discussion with the patient. I go over the side effects with them for each of the agents. In full disclosure, I probably do not choose regorafenib as my go-to for the third-line setting if the patient's a KRAS mutant tumor type or a RAS mutant tumor type. So we have to think about these oral agents in the third-line setting if we don't have a clinical trial. I discuss the schedule and the dosing and go over the potential side effects, and we make the informed decision together in full fairness. It's not that I just say, oh, I'm going to choose this for you because I was involved in this study. I don't look at it that way.
Okay, excellent. And what's next? What's on the horizon? You're in the thick of it in colorectal cancer.
Well, so are you. But I really am looking forward to some of the new agents. Obviously, we have a lot of interesting drugs in regards to the RAS mutations. For codons 12C, we're moving forward with 12D development. There's pan-RAS inhibitors that are being developed. There's also, you and I were talking earlier, there's some CAR T studies that are being considered for phase 1. And so I would just encourage all patients and providers, please refer to us at academic institutions. If you do not have a clinical trial available, please refer to us early on in the 3rd line setting or 4th line setting if RAS wild type, because we want to be able to develop that rapport with the patient and hopefully get them informed earlier on about available clinical trials. There's just a lot of interesting agents out there. The antibody drug conjugates are really exciting as well. There's a lot of newer ones that are being developed in phase 1. So it's a great time to be involved in colorectal cancer.
Yeah, excellent. It does feel like we're coming up with many topics for future episodes. Hopefully we have some successful trials in ADCs, in RAS, in particular pan-RAS. That'd be super cool.
I know.
And my bias in immune therapy, but we'll see if we actually get there. Today we've had Dr. Cathy Yang discussing the treatment of refractory colorectal cancer. We've discussed trifluridine with tipiracil plus or minus bevacizumab. We've discussed regorafenib and the new kid on the block, fruquintinib. We've talked about the risks and benefits of trifluridine with bevacizumab. It does have an association with cytopenias. We have to be cognizant of that. We have to be careful when using bevacizumab for those patients with contraindications. We talked about regorafenib, which is an important innovation in the use of TKIs in colorectal cancer, but it does have limitations, in particular in terms of toxicity. And then the more recently approved fruquintinib, which, like regorafenib, is an oral agent, like regorafenib is a VEGF TKI, but it's more targeted and probably has a better safety profile. But ultimately, these are patients who are best served by clinical trials, but when not available, these are good options that can be safely given with good patient education. Thank you so much for joining us. This is Dr. Benjamin Schlechter for In Discussion.
Thanks for listening to Medscape's In Discussion Colorectal Cancer podcast series with our host, Dr. Benjamin Schlechter. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on colorectal cancer.